It's my pleasure now to introduce Dr. Wayne Terrace, who is our Chief Medical Officer of Care Compass Network. And I think that you'll find in this brief bio maybe some things that you don't know about Dr. Terrace's background, which I found very interesting. Dr. Terrace earned his Bachelor of Science degree in biology, his Doctor of Medicine degree from the University of Pittsburgh, and a graduate certificate in biomedical informatics from Oregon Health and Science University. He completed a family medicine residency at the Washington Hospital and is board certified in family medicine. He's been named as a fellow of the American Academy of Family Physicians and is credentialed as a certified physician executive by the American Association for Physician Leadership Certifying Commission in Medical Management. After his residency training, Dr. Terrace began his career as a family physician and chief of family practice services at Air Force hospitals in both North Dakota and Virginia, receiving a commendation medal while on active duty for 4 years. He was then an emergency physician at Walter Reed Memorial Hospital in Virginia before moving to Binghamton and working with Associates in Medicine and UHS Medical Group as a family physician for the next 27 years. He subsequently was physician advisor and chief medical information officer at Ascension Lourdes Hospital in Binghamton prior to joining Care Compass Network in September 2017. So Dr. Terrace, the floor is yours.
Okay, good afternoon, everybody. So there's quite a bit of information to go through today. Buckle your seatbelts. Much of the information on here, I'm going to go through fairly quickly, but we will distribute a PDF of the presentation for your reference. I have, we entered 2022 with great trepidation, as you can see, and we're starting to see the light at the end of the tunnel, recent world events excluded. What I wanted to do was, I have several goals today. I really would like everybody to be able to look at this extreme amount of data and really, and the arguments that you see on social media, and really be able to evaluate them in some sort of logical way. So I'm going to talk about some logical fallacies as they apply to the discussions. And I think as we go through those, you will recognize a lot of what you see on social media and hear about in the mainstream media. CDC has recently revised their guidelines for prevention of COVID-19, and I'm going to go through those. We're going to talk a little bit about what are the current isolation and quarantine guidelines, because those did change recently, and we'll try to simplify that for you. I want to discuss some misconceptions that we commonly hear. And also there's a lot of talk about what's an epidemic, what's a pandemic, what does it mean when we're endemic and we have herd immunity. So we'll discuss that. And additionally, the White House just released in the last couple of days a new COVID-19 preparedness plan looking forward. So I'm going to just go over the highlights of that. May seem a little weird, but you'll see where I'm going with this. So we're going to start with World War II fighter planes. And what happened was the Allies from their bases sent fighter planes off into battle, and they came back. And what they did was they charted, where are the bullet holes? Where are these planes getting shot? And what they really wanted to do was figure out a way to reinforce these planes so they wouldn't lose so many of them. So here's where the fighter planes were shot, as you can see. And I have a polling question for you. And what the polling question is, looking at these patterns, looking at the data that you see in front of you, where should the Allies have reinforced those planes? Should it be in the areas where the red squares are, which we'll call A, or should it be in the areas of the blue squares, B? And I'd like you to go ahead and vote, and let's see what the group comes up with. Okay, so we're evenly split pretty much with slight preference to the area outlined in blue. So let me show you where I'm getting at with this. So during World War II, these planes would come back from battle, and the Allies initially chose the most commonly damaged parts. They said, these are the damaged parts, so this is what we're going to reinforce. And they wanted to reduce the number that were shot down, but lo and behold, it didn't help. So they had a mathematician, Abraham Wald, that looked at this and said, let's sit back and look at the data a different way. And maybe the reason certain areas of the planes were not covered in bullet holes was that those planes were shot down. So they never came back. So using this insight, they actually started reinforcing the planes where there were no bullet holes, and lo and behold, that prevented loss. And this is what we call lateral thinking. So basically with lateral thinking, you look at the data. It may seem immediately obvious, but you step back and try and think creatively. And this is what happened here was, initially it seemed very obvious that, this is where the bullet holes are, this is where we reinforce them, but actually the opposite was true. So it's just a different way of looking at the data. And I have one more question for you here. Now, again, think about the data. So you see a lot of stuff on social media. Well, my gosh, I'm looking at this, and 50% of the COVID cases are fully vaccinated, and 1/4 of the people in the hospital are fully vaccinated. So these vaccinations are not working as expected. They're not working. Why bother? So let's bring up the next question. So given the statistics that you see, does this mean the vaccines are not working as expected? And the yes answer means, yep, they're not working because half of the cases are fully vaccinated and 1/4 of the people in the hospital are vaccinated, or no, they are working as expected. Go ahead and vote. And let's see what we came up with. They are working as expected. You're a very smart group, but I want to show you where I'm getting at with this one. So bear with me. This is a typical COVID conundrum. So let's look at the data. So I think we can reasonably assume if somebody's exposed to COVID and they are vaccinated, let's say it's 80% effective, so 20% of them will get COVID. If they're not vaccinated, 80% will get COVID. So this will lead to the conundrum. Starting on the left, if 100 people are exposed to COVID and none of them are vaccinated, so 100% of them are unvaccinated, right? And you're going to have 80 cases because 80 out of that 100 unvaccinated will get COVID. Now let's go over, let's say, to the 40% column, the next one in green. So now you have 40% people vaccinated and 20% of them get COVID. So you have 8 cases, right? And let's say you have 60% unvaccinated. So 80% of the 60% will get it. That's 48. So you have less total cases, right? 8 plus 48, you have 56 cases. And out of those cases, 14% are vaccinated and 86% are unvaccinated, right? Now we move over to the column, we're trying to get 80 to 90% of the public vaccinated. Let's say we've gotten to 80%, right? So how many cases are we going to have? Well, 20% of the 80, so that's 16 cases. 20% of the people are unvaccinated. Okay, so you're going to have 16 cases because 80% of them will get it. So now the total cases are 32, but look at this. Half the cases are vaccinated and half are unvaccinated. So it's counterintuitive, right? That's the conundrum. So the more people you vaccinate, the higher the percentage of people that get cases will be vaccinated, right? And it's just the math. It doesn't mean that they're not working, as most people thought. It's just a matter of the math. You got to look at the data, okay? So I'd like to just quickly go through what we call some logical fallacies. These are the fallacies and the arguments that people make all over social media, on Facebook, etc. And you could talk about this for hours, but think about what you have seen. Think about the arguments you've heard from the naysayers. And I'm just going to quickly go through what are the most common fallacies. And what I want you to do moving forward is when you see one of these discussions, think about these and think about what could be wrong. So, if the COVID vaccines actually work, why are vaccinated people getting COVID, right? So this is what we call the false dichotomy fallacy. This is taking a subject that's really complex, such as COVID and vaccination, and really you're asserting there's only two possible explanations, right? Some are suggesting that infections after vaccination means they don't work. Well, of course, we know no vaccine is 100% perfect, and vaccines work if they significantly reduce the risk of getting infected or hospitalized or dying. It's not totally eliminated, and it's just kind of like seatbelts, right? By putting the seatbelt on, you don't guarantee you're not going to die in a car crash, but your chances are certainly a lot less. So it's a similar scenario. The appeal to authority fallacy. This asserts that anybody with a degree, authority figure, must be right. Here's a doctor that says you're wrong. He's an MD, he's a PhD, she's a PhD. But you know what? It doesn't matter who's saying it. It's the data and the analysis that really matter. So, you know, sometimes scientists with a lot of credentials are better at recognizing the good data, but they might latch onto bad data for a variety of reasons. But how do you tell the difference, right? Well, you look at who's saying it, and you look at what the majority are saying, and you look at, you know, you talk about vaccines and pregnancy, and every professional organization recommends them. You know, College of Obstetricians and Gynecologists, neonatologists, everybody. So you look at the big picture. You don't look at what one person is saying. You have the rhetorical strategy, and this isn't really a fallacy. It's a strategy, and what it is, you know, repeatedly asking questions over and over, the same thing to engage in bad faith debate. And you've seen this probably when Dr. Fauci is testifying in front of the Senate. You're pretending to engage in honest inquiry, but really you're not going to be satisfied no matter what the person says. And really the goal of this is to spread doubt through just repeated questioning and harass the person to the point of exhaustion while maintaining a pretense of inquiry. And ultimately, you know, if the one being questioned stops responding, then the questioner says, see, I've won the argument, I'm right. So it's just basically wearing somebody down. The false equivalence fallacy. I've seen this one all over. You know what? Doctors don't talk about diet and exercise anymore. You just eat healthy, exercise, live a good life. You're not going to get this. Well, it's attempting to make things seem equivalent that aren't, by emphasizing shared features. So healthy diet and exercise are indeed, of course, very important. They're not equivalent to vaccination, right? I mean, vaccines train the immune system to recognize the virus. Diet and exercise don't. Vaccines work quickly. Diet and exercise are more a chronic lifestyle change. You know, healthy diet and exercise take a significant effort. Vaccines are free. So they're not equivalent. They're both important, but of course, again, the naysayers are attempting to make them equivalent. This is one of my favorites. It's called the Posthoc fallacy. So you've all heard of the vaccine reporting system, adverse event reporting system. This is a thing on CDC. Anybody can report anything to it. You can report it. A physician can report it. And what this fallacy is, if event A comes before event B, then A must have caused B. Okay? Not true. Correlation does not equal causation. Those of you that heard me before have heard me say this. So the misinterpretation of this database, I see this all the time on social media. It's a prime example. Just because a negative event occurred shortly after vaccination, it doesn't mean the vaccine caused it. It means it occurred after. And again, particularly with this reporting system, anybody can report anything, right? So CDC very carefully takes these reports, first of all, verifies them, looks at the cases and studies them, and looks at the big picture to see if certain health events are occurring more often after vaccination. So first, what they do is verify that the event really happened. And second, they look at the big picture. I had another example that I previously alluded to early on. This is another one of my favorites. So part of the reporting system with the initial run of vaccines was a number of factors, and one of them was heart arrhythmias occurring within 28 days. So there was a case of somebody in Europe that had the vaccine, and 28 days later, they had a heart arrhythmia, and this was reported. Did the vaccine cause the heart arrhythmia? Well, they investigated the case, and go figure, the person was struck by lightning 28 days later, and that's why they had a heart arrhythmia. So, you know, go figure, you got to look carefully at it. And, you know, just to emphasize, correlation does not equal causation. So let's say we take 10 million Americans and we give them a sugar pill and we watch them for 2 months, right? you can see on the right side of the slide here what's going to happen. 4,000 of them are going to have heart attacks, 3,900 strokes, 14,000 deaths. Does that mean the sugar pill caused the heart attacks and the blood clots and the strokes and the deaths? No, no, it's correlated, but it's not caused by the sugar pill. The straw man fallacy. So here, you said vaccines are safe, but there's side effects. I saw it. I looked at the vaccine, the VAERS, and there's all kinds of side effects. So somebody will give the impression of refuting an argument by mischaracterizing it, oversimplifying it. Sure, we say vaccines are safe, but there are possible side effects, and the benefits outweigh the risks. So it's a nuanced discussion, but it's taken out of context and just mischaracterized. And it takes a nuanced statement about vaccines and just overly simplifies it and then refutes the false simplified version. And if you just think about what you've seen out there and heard, I think you can recognize this. Ad hominem means to the person. And what this is just, and I guess I'll allude to Dr. Fauci again, you're a puppet of evil. You only care about yourself. The person doesn't directly address the topic, how well do the COVID vaccines work, but instead they just personally attack and insult the person repeatedly. And because it is hurtful, a lot of people then become defensive and the discussion just deteriorates. We've all seen this one. The anecdotal fallacy, another favorite of mine. People use their limited personal experience to make sweeping conclusions about a given topic. I think the one that was in People magazine was Nicki Minaj's cousin's testicles swelled up after they had the vaccine in the Caribbean. But my friend and I both had tooth pain after getting vaccinated, therefore vaccines cause tooth pain. Or no one I know had side effects from vaccines, therefore vaccines don't cause side effects. Well, of course not. This is done very commonly. Everybody's anecdotal personal experience. It's not enough to decide. It assumes that your limited personal experience is enough to know when the symptoms are coincidence and when they're not, but you really have to look systematically across large groups of people. The red herring fallacy, Dr. Fauci again. Who funds you? Who funded this study? It had to affect your thinking. Well, it's very commonly posed to people who discuss vaccines, but really they're not discussing the issue at hand. They're shifting to a different topic. And if the scientist really is biased and it's influencing their interpretation, then a logically valid rebuttal would point this out. And this is often directed at scientists, but scientists receive grants all the time to do their research. This is not unusual. The base rate fallacy, 50% of COVID hospitalizations are vaccinated people. Well, remember, we just discussed that previously. People try to estimate the chance of something happening based on specific examples in front of them, ignoring background levels. So we talked about, the higher percentage of vaccinated people, the higher percentage of hospitalized patients will be vaccinated. And we saw why. You really need to know the base rate. So those are the fallacies, and I just urge you to think about those as you look at social media and you listen to people argue this. CDC guidelines. So they were just revised February 25th. And previously they talked about levels of community transmission. And right up until they revised these, probably 90 to 90% of the counties in the US were classified as high transmission. Lots of mitigation was recommended. So previously what they looked at was cases per 100,000 people and percentage of positive PCR tests of the previous week. But now that we're into more, first of all, the Omicron variant, which is much more transmissible, but less severe in most people, what we really want to look at is what's the effect on our healthcare system. So they still look at the cases per 100,000 people over the previous week, but now they incorporate data that looks at COVID hospital admissions and percentage of beds occupied by COVID patients. And they come up with three categories: low, medium, and high. Those first indicators were developed really in fall 2020 prior to vaccines, but this now, it's more appropriate to focus on factors that reflect the severity of disease and not just on cases and test positivity. And there's a really robust scientific argument for this. If anybody really has a lot of spare time and wants to look at it, there's a huge slide deck and a recorded webinar how they come up with these guidelines. So basically, what they did is develop a grid. The actual numbers aren't important, but I just wanted to show you their logic here. So they look at either fewer than 200 cases per 100,000 in the past 7 days or more. And then they look at the other indicators, the admissions and the percentage of staffed beds, and they come up with a category low, medium, or high. So this slide I actually revised about an hour and a half before this presentation. So the initial run of this was done on February 24th, last Thursday. And the map and the chart on the upper right there are both from that date. And basically, if you look at what I did is I looked up our counties in our region, and on February 24th, Broome, Tioga, and Tompkins were all rated as high based on those criteria. And then you can see what the others were. And now I looked, and just this morning, they changed it yesterday afternoon. It looks like they're going to update this every week. And you see what happened. Broome, that was a high, is now medium. Tioga is a medium. Tompkins went from high to low, believe it or not. And you can see there's a lot more green. And if you actually go to the website and pull up the map, there's a lot more green than there was a week ago. And that's a good thing, right? So right now, none of our counties are high, which is good. And here's what they talk about doing. This is the summary. So if you're in a low risk area, stay vaccinated, get tested if you have symptoms. If you're in a medium risk area and you're a higher risk individual, talk to your healthcare provider. Should I really just keep wearing a mask? And again, vaccines and testing. And then the difference is in the higher risk areas, they do recommend masking indoors in public. Okay. There are, and I won't go through this in detail. This is all on the CDC website. What I did is I highlighted some things because you see the same themes over and over here. Vaccines, boosters, isolation and quarantine when appropriate, getting tested if you're exposed or have symptoms. If you're immune compromised or at high risk, you want to make extra plans. That's the individual strategy. Then you have community level strategies. Vaccines, improved ventilation, easy access to testing, a lot of talk about equity. So you will see these same themes when you get up to the medium level. As I said, if you're immune compromised, talk to your healthcare provider. Vaccines, boosters, ventilation, isolation, quarantine, all the same stuff that's very important moving forward. And then the difference is in the high community level, and I circled it in red, wear a well-fitting mask indoors in public, regardless of vaccination status, including in K-12 schools and other settings. So this is here for your reference. This will be distributed. I'm not going to go through it in detail, but what you can see is the same themes over and over again. So this happened recently, right? The governors ended the mask mandate in schools because we've stepped up. We can confidently remove the mask mandate. And Jason Garner said same day, I support the decision. We'll end the mask mandate in our schools and we'll take no action. Another one of these COVID conundrums, right? On the day of that announcement, Broome County was in the high category, and CDC recommended a well-fitting mask in indoor public settings, including K-12. So for the first time in my memory, since all this started, New York and the county actually diverged from CDC guidelines, and they went ahead and removed the mask mandate. But as I said, good news, as of today, we're down to the medium category. Speaking of children, so I got an anguished call from one of my sons that has 3 kids, and 2 of them are vaccinated. He said, I just saw on the news that those vaccines only work 12% of the time, right? Okay, step back, take a deep breath. Let's see what this is all about. So there was a study done by the Department of Health and the University of Albany, and it was what we call a preprint. Now, before this pandemic, we never used to see preprints, right? It was a scientific thing. But this is what the authors of these studies submit to a site. And this is before it's analyzed, it's peer reviewed, it's not in a professional journal, it's just an initial run of the data, an initial reveal of what they found. So there was a preprint, and of course the media got a hold of it. And what it was about 1 million children in New York. This was analyzed. This was 5 to 11-year-olds, 12 to 17-year-olds from mid-December through the end of January. Now, the height of the Omicron surge was right in the middle of this, and they looked at what they thought was vaccine effectiveness against infection and vaccine effectiveness against hospitalization. So what they found pretty consistently was effectiveness seemed to decrease or wane about 28 days after completion of the primary series. And much to everybody's chagrin, it seemed to be much faster in the 5 to 11-year-olds. So their effectiveness started at 68% against infection, was down to 12%. And the 12 to 17-year-olds, it went from 61 to 51. Now, against hospitalization, it seemed to wane from 100% down to 48% over that period of time. And in the 12 to 17-year-olds, 85 to 73%. Whoa, what's going on here? Well, a lot of things. First of all, when the analysts really looked at the data, started looking at it, the numbers of hospitalizations were so low, they really don't think those numbers are particularly accurate. In fact, in the 5 to 11-year-olds, they really said, it's somewhere between 0 and 75%. Okay. So they don't really think that's accurate. And what they really need to start looking at is the dosing. So the 5 to 11-year-olds got 1/3 of the dose. So they said, let's compare 11 to 12-year-olds and see. So in 11-year-olds, it went down to 11% effectiveness against infection. In 12-year-olds, it was 67%. And the bottom line here is we need more data, right? This was a lot of kids, but it was a relatively short period of time. The younger ones got 1/3 of the dose. And really, we need more data in terms of dosing and possibly boosting those kids. So it may be, what they want to do in children is give them the dose that's going to be effective, but not cause high fevers and too many side effects. And they had some clinical studies and they had pretty good data, but now we're doing this, over a larger period of time with more kids. Another study came out, and this is in the mortality MMWR, Morbidity and Mortality Weekly Report. They released it on March 1st. Officially, it's published today. So this study looked at visits to the ER, urgent care, and hospitalizations. And this was a bigger study. This was across 10 states in 5 to 17-year-olds. And this was over a longer period of time. And I won't go through a lot of detail on these numbers, but basically it almost said the same thing, that the vaccine effectiveness reduced over time. But here they looked at the 16 to 17-year-olds that got boosted, and the effectiveness had gone down to 46% and shot up to 86% after the booster. So it helped in that age group. And the good news was that the hospitalization effectiveness, there were more hospitalizations because it was a bigger group over a longer time. And they found with this more robust data that really was very effective against hospitalization. So what's the takeaway in children and adolescents? Okay, there's always going to be some ambiguity. The studies are done differently. Some are preprints, others aren't. We still need more data. We're still early in this. But beware of data that just comes from preprints or other sources that are not peer-reviewed and published in professional journals. And of course, in the middle of this, Omicron threw a monkey wrench in because they started studying this with Delta, then Omicron kicked in. It changed everything. But it's clear, even with the data that we see here, that vaccines really do work well to prevent severe disease in children and adolescents. And, the numbers are not insignificant. If you look at percentages, a very low percentage get severe problems, such as that generalized inflammatory disorder, things like that. But, children die and children get this, and one is too many. So the vaccines work very well preventing severe disease in children and adolescents, and boosters do improve protection in adolescents, and we got more to come for the 5 to 11-year-olds. So I think in the 5 to 11 group, they may adjust the dosing, they may recommend boosters. All the data is being collected. Dosage matters, boosters are important. This is not meant for you to read. It's obviously very busy and small, but it's a great one-pager as far as the pediatric vaccines and what the concerns are, and to allay some of the anxiety. And I have a link here that if you're interested, you can go to, and you can actually download this and look at it. Those of you that have seen me talk know that I use this a lot. This was a risk calculator. At this point, especially as things are in the downhill slide, we all assess our risk before we do anything. We get in a car and put our seatbelt on, hopefully, and travel. Or are we going to drive, or are we going to fly? What's riskier? Everything we do involves risk. Risk is never zero. But what we want to do is have good information here. And what this group at Georgia Tech did, excuse me, is they came up with a calculator. So you go to this website, I have a link, and you say, I anticipate being in a room with 50 people in Broome County, New York today. what is the risk that somebody in that group has COVID? So I did this a couple of days ago, and the risk was 42%. So, 50 people, you're in a small supermarket or a restaurant, and there's 50 people. It's almost a 50% chance somebody's got COVID. So are you going to go out to eat and take your mask off to eat? Are you immunized? Are you boosted? Have you had COVID? You got to weigh all this when you decide what it is you're going to do. It's never going to be zero, folks. So I think this is nice. And if I were you, I'd go play with it and look at numbers. And I think it's very helpful. I know that early on, there was a lot of talk, COVID's nothing but the flu, it's nothing but a cold. And indeed, back in July of 2020, before vaccines, before we knew how to really treat this, it was over 20 times more lethal than the flu. And now it's about twice. So that's the good news. We have a lot more immunity in the community. Vaccines are much more widely distributed, and we're getting to the point where it's not much worse than the flu in terms of lethality. But the problem is the long COVID, and I'll talk about that. It's still not the flu, even if we get it down to the same levels of death. Talking about risk, and I won't read through all of these, you can look through this, but basically, one of the epidemiologists took a look. So let's say you're a 0 to 4-year-old, you get COVID. So MM equals 1 in a million. So 227 out of a million will die. About the same risk of a mother giving birth. Going down to the fourth one, an unvaccinated 65-plus-year-old, the risk is about the same as a 1.5 years of heroin use. Wow. So I think probably it's wise to get vaccinated, right? For a boosted 65-plus-year-old, the risk of dying after infection is about the same as a baby the first year of life, or a little bit riskier than 1 year of active service in Afghanistan in 2011. It's an interesting exercise to look at, everything we do and what the particular risks are. I want to talk a little bit about isolation and quarantine and the new recommendations, and just simplify it and allay. So they are two different things. Isolation is not the same as quarantine. So isolation means you're separating sick people with a contagious disease from people who are not sick, right? So you have COVID, you're isolating. Quarantine, on the other hand, will separate and restrict the movement of people who were exposed to a contagious disease to see if they become sick. So this is after exposure, two different things. So what are the new recommendations? So CDC backed off on these a little bit recently, and what it is now, and it gets really confusing, but here's the recommendations. And this one is if you test positive for COVID. And this one is irregardless of whether you're vaccinated or not. If you test positive for COVID, you stay home for 5 days. And on day 6, if you have no symptoms or your symptoms are significantly better, at that point you can leave the house but wear a mask until day 10. And there was scientific evidence behind this, looking at severity of disease, how long you're communicable to others, et cetera. And so this is the new isolation recommendation from CDC. And there's a flow chart you can look through, but basically it takes you right through. But essentially you have a positive test, you have symptoms, you stay away from everyone for 5 days. You don't have a fever for 24 hours, you're feeling better. You can end strict isolation, but you wear a mask for another 5 days. Okay. Quarantine is different. Quarantine recommendations depend. You are up to date on vaccination. So definition here, fully vaccinated means 2 doses of the Pfizer or the Moderna, or 1 dose of the Johnson & Johnson. Up to date vaccinated means also that you've been boosted. Okay. And CDC looks at up to date. And the reason for this is that with the Omicron, the booster is very important. So if you were exposed to COVID-19 and you've been boosted, right, and this applies to 12 and older because that's who's eligible to be boosted, you don't have to quarantine, but do wear a mask for 10 days. And they do recommend getting tested on day 5 just to be sure. Now, if you're exposed and not boosted and eligible to be boosted, you stay home, okay, for 5 days. And then you test on day 5 if possible, but basically you're home for 5 days. And then on 6 through 10, you wear a mask around others. All right. So that is quarantine. Now, questions about vaccines and misconceptions. So, you hear all kinds of stuff still after all this time. Do they really work? Are they safe? Are they necessary? And then you hear all this stuff. There's still a big group that believes COVID-19 is overblown and it's a conspiracy, and boosters are overkill. It's too many shots. And pregnancy is a very important topic that I want to address. Vaccines aren't safe and they cause infertility. And I'm young and healthy and I already had COVID. I don't need a vaccine. And I've seen the term face diapers and muzzles and all the rest of it referring to masks. They don't work anyway. The whole thing's ridiculous. Unfortunately, I just saw a shot where the governor of Florida lambasted a group of high school students behind him at an event because they were wearing masks and told them it was ridiculous. This is unbelievable. So COVID-19 is overblown. Well, no, it's not. I mean, we've had close to 80 million cases, 1 million deaths almost. It's the 3rd leading cause of death in this country right now. And I'll talk a little bit about long COVID. I think that's an upcoming public health crisis. So what epidemiologists do when they look at this is they do something called excess all-cause mortality. So you see the red line and the orange line right below it. But that line, what happens is over time, epidemiologists look at for a given month of the year, how much mortality do we expect based on what's happened in the past? And then what they've looked at is if you see something far in excess of that, you got to say, why is it? So if you look at May 2020, what starts happening? You see those little red pluses and all the blue lines above the red line, that's excess mortality since COVID started. And if you add those numbers up, it's almost 1 million. So there was no other factor that could have caused this. It was COVID. You hear the naysayers say, no, it's not. It has nothing to do with anything, but here it is. And this is a very, explicit, commonly used scenario. Epidemiologists, infectious disease experts have been using it for years. Long COVID, there was an article in the New England Journal confronting our next national health disaster, long haul COVID. And this is very important. It's not just the flu. It's not a cold. A lot of people have really significant ongoing symptoms. This is one study of many. This looked in 1-year outcomes and survivors and at 6 and 12 months. And you can just read down the line and look at all these symptoms that persist in many people. And I can tell you that even in people that didn't end up in the hospital, had less severe cases, the same thing happens. Long COVID is very significant, and it happens in children, about 10% of children. This was a little scary. This was a study in the UK. They looked at MRIs in COVID patients versus matched controls, and COVID patients had anatomical structural changes in their brain, shrinkage. So brain fog, foggy thinking, I'm exhausted all the time, probably has something to do with this. Don't need boosters, too many shots. Well, do need boosters, not too many shots. So this is weekly hospitalizations for US adults, and you can see unvaccinated, vaccinated, no booster, vaccinated with booster. And you can see what's going on. Now, the reason for the spike is Omicron, and it's not that Omicron is more severe, it's just the sheer numbers. Less people with Omicron percentage-wise get admitted, but there's been so many of them that the sheer numbers have gone up. So that's one study. This is from CDC, and here's another look at it. And here we're pointing out the start of Omicron predominance. So on the left, this is cases per 100,000, and you can see the solid line is unvaccinated. The dashed line is fully vaccinated, but no booster, and the dotted line is with the booster. So on the left side, it's cases. On the right side is hospitalizations. You do see the cases going up. You do see the breakthroughs on the left because Omicron breaks through, even in the fully vaccinated and boosted. But look what happens on the right. They're not hospitalized, right? So it's doing what it's supposed to do. It's keeping people out of the hospital. Very important. Fertility. All kinds of stuff out there on this one. And I can say that there is no scientific evidence that vaccines will cause infertility in women. It will not prevent women from becoming pregnant now or in the future. every national and global professional organization is recommending vaccination right now for those attempting pregnancy, those pregnant. Here's what the confusion was. There was a false report on social media early on. There's a spike protein on the coronavirus. You've all seen those pictures. There's a protein called syncytin-1 that's a spike protein on the placenta. And it was alleged that they're the same structurally, and therefore vaccines will attack the syncytin-1 and it will fight the protein. They're completely distinct. They're different, and it is simply not true. And people can talk about it all they want and raise it up on social media, but it's not true. Pregnancy. Pregnant people that get COVID, severe illness, more likely to go to ICU, more likely to need oxygen, preeclampsia, death, stillborn, preemies, admissions to the neonatal unit. CDC, ACOG, College of Obstetrics and Gynecology, and Society for Maternal Fetal Medicine all strongly recommend the vaccines for pregnant people. I have a link at the bottom there if anybody's interested. This is unequivocal. And this is another one of those one-pagers for anybody who's interested. Again, it's too small to read, but I have a link to it if anybody's interested. The thing about getting immunized after you're infected, don't need it. I've been infected, but I can tell you that the antibody response following a confirmed infection is highly variable. And the vaccination provides a much stronger and more consistent antibody response. And not only that, but the vaccination provides other types of immune responses. The antibodies are shorter term, but then there's T cells and B cells and other parts of the immune system that are stimulated strongly by vaccination. So, you see the little spaceship. Everybody needs that turbo boost, and vaccination and boosters are recommended for everybody. Masks are just face diapers. They don't work. Not true. So here's a study, and this was actually done before Omicron, which is much more transmissible. This was done during Delta. And if neither party has a mask on, then it takes about up to 15 minutes to transmit an infectious dose of COVID. If on the x-axis there, the person not infected is wearing an N95 and the infected person is wearing nothing, you're still protected for a couple hours. The most important one is in the bottom right. Both parties have an N95. It can take up to 24 hours, 25 hours. So masks do work, and they are important. And especially now we're entering a time where some are going to be wearing, some aren't. Everybody's got to, assess their risk tolerance, and are they averse, and are they going to wear a mask? So I can tell you that one-way masking does work. Okay, there was confusion about this in the beginning, but as you yourself are looking at your own risk, and let's say, somebody has small children, they're not yet immunized, and they want to go work in an office setting and they don't know what to do, that may be a person that wants to wear that mask at work for a while or try to stay away from other people. So it's a continuum, but I can tell you that what's recommended now is an N95 or equivalent, not a cloth mask. So an N95 is the best. They're readily available now. And I know at the beginning they said don't use them if you're in the public. That was because there were so few and they wanted to have healthcare workers have good access. But N95, or there are equivalents. There's a KN95 from China. Some people don't like the N95s because it goes back around. There's two straps that go around the back of your head versus the KN95 that goes around your ears. They're pretty effective, as are the KF94s from Korea. So if you're going to wear a mask, wear one that works. Finally, we want to talk about, are we entering what's called the endemic phase? Or, what is that? What's an epidemic? What's a pandemic? What does it mean to be endemic? So an epidemic is a disease that spreads unexpectedly across a large number of people within a community or a region or a specific population. And one example of that was Ebola back in 2013. A pandemic is an epidemic that spreads over multiple countries or continents, worldwide spread of a new disease. Spanish flu back in 1918 or COVID-19 pandemic. What is endemic? Well, that's a disease that's always present in an area. It's restricted to particular locations or regions, and the prevalence is fairly stable and predictable over time. So For example, malaria in parts of Africa. It's endemic to the area. They have ways of dealing with it, but it's there. Influenza in the United States, right? It comes around every year. There's episodic seasonal flares. It's always there in the background. But for the most part, we pretty much know, what's going on with it. We have ways of, we have immunizations, we have ways of treating it. And this is just kind of a graphical representation. So on the left, endemic disease is present in a population or region, relatively low spread. Epidemic, sudden increase in cases, boom. And then pandemic, you can see it's basically around the world, and that's still where we're at. I mean, is COVID-19 endemic yet? No, it's not. I mean, we're on the downhill slide here, but it's too soon to tell. There are large differences even within the United States as you look at that CDC map, big differences between different regions, different counties. Too soon to tell. We could get another variant. We could get behavior that we don't understand yet. We're not quite there. So nobody can truly say what the future looks like due to unpredictable behavior, such as emergence of variants with different characteristics. And, endemic does not mean harmless, but what it does mean is ongoing vigilance. And I like, those of you who know me know I like these little acronyms. This is California's approach, and this is what they're going to. So it's smarter, right? So S is shots. Widespread vaccinations continue to be important. You saw that on those CDC one-pagers that I showed you before. M is masks. Stockpile them. Have them ready. So if we get another variant or we have to step back and reinstitute some of these things, we've got them. Awareness, and this is where I think it's just been an utter failure, is really understandable information. The communication, it's just been very confusing, continues to be confusing. I hope we've learned a lot of lessons. Readiness, do ongoing surveillance to prepare for surges. How would you like this job? It's called wastewater testing. So they look at the sewer water basically from an area. The area can be a building. They were doing this at Binghamton University. It can be a city. It can be, but what they do is they examine the wastewater for snippets of the RNA or snippets of the virus, and they really get a good sense of where we at. If they start to see an upward surge, something's coming. And this is thought to be a very good epidemiological way of looking at this. So readiness, let's do ongoing surveillance, ongoing testing, get on top of this before the next surge happens. Testing, increase lab capacity, make testing readily available, home tests, education, ensuring safe shift to in-person instruction in schools. We all know that's important. We want the kids back in school, hopefully without a mask. And finally, prescriptions, RX, make treatments readily available and accessible. The smarter approach. So on the heels of that, just released from the White House is a 96-page plan for your spare time reading, National COVID-19 Preparedness Plan. And it is a smarter approach, I'm happy to say. I haven't read the whole thing, but I've looked at some of the goals and some of the highlights, and this is what they're doing. It really is an excellent plan. It's going to require funding. There's going to be arguing back and forth in Congress, but they're spot on with this. So what are the goals? We want to protect against COVID. We want to be able to treat COVID when it happens very easily. We want to be prepared for new variants. We want to prevent all these shutdowns of the economy and educational shutdowns. If we get on top of this early next time, we won't have to do that. We need to vaccinate the world, right? We don't live on an island here. What happens in the rest of the world affects us. If we don't get the world vaccinated, we're going to have these nasty, ugly variants that are going to make their way over here. So that's the goals. And some of the highlights from the plan. Test to treat. The idea is to have a lot of pharmacy-based clinics for one-stop shopping. You get your test, they run it there. If it's positive, here's your Paxlovid from Pfizer. Take it for 5 days. One-stop shopping. Improve tracking, additional funding to improve the infrastructure, the data exchange. Universal vaccine. They're working very hard on a pan-corona vaccine. They're looking carefully at these spike proteins and looking for commonalities, and they're trying to basically develop a vaccine that will remain effective in spite of the variants. There's a lot of work being done there. Vaccines for young children, they're still arguing back and forth about that, but they want to make them widely available once the FDA approves. Immunocompromised Americans, prioritization, outreach, priority for antivirals. FEMA, working with the private sector to proactively prepare for the surges so we don't get caught with our pants down again like we were. So hopefully a proactive approach. Research on long COVID, I talked to you about that. It really is a public health crisis. Anecdotally, my sister works for the Social Security Administration as an attorney, and they are getting tons of applicants now from people looking for disability due to long COVID. They just can't work. They're exhausted. They've got brain fog. Their whole body hurts. A lot of nurses, unfortunately, with this. And other healthcare workers, and then continue to distribute masks. Hopefully we get away from these masks for the most part, but they're looking at the wastewater, the numbers are going up again, we're starting to see a surge. Get those masks on. This is going to be the tough part, is communicating this to the public and realizing that this is always going to be there, and we have to be prepared to respond proactively. And again, those of you who have seen me talk know this is my last slide. This is Swiss cheese. But it's so important that this is the takeaway. So no one thing is going to get rid of this, right? So that nasty little spiky coronavirus on the left goes through the holes in the Swiss cheese. And if we don't, provide these mitigation efforts and close those holes, it's going to get all the way through. So, to the left is your personal responsibility. Stay home if you're sick, physically distance, wear your mask, hand hygiene, cough etiquette. Don't touch your face. If it's, crowded in a room, limit your time, all those things. It's kind of funny. You see the cute little mouse eating away at our Swiss cheese. So we've got all these other mitigating factors. I would say the naysayers and the misinformation are probably the little mouse eating away at the Swiss cheese. And then shared responsibilities, testing, tracing, adequate ventilation, air filtration, quarantining and isolating when you should, government messaging, financial support, and finally vaccines on the right. So it's everything. So that's it. We made it. Thank you. That's the end. And I did have a good question here that I want to share with the group. Did the vaccine cause the individual to get struck by lightning? We're going to have to look at that from earlier in the presentation. So I'll stop the share and see if there's any questions.